Today, I'm going to answer the clinical questions from my best friend by introducing four very simple clinical cases. First one is socket preservation procedure only with patient own blood, not using any other graft materials. Other three cases are very simple socket preservation technique using moldable auto-BT dentin powders. With these four cases, I will try to answer the question from my best friend appropriately. This is a question case from my friend. Left is before extraction of root rest on lower right first molar. You can see the radiolucent lesions around the root apex. That means inflammation in and around the bone. Middle is the socket preservation with hydroxyapatite materials immediate after extraction. Right is the 6 months after the operation. The question is whether the demarcation line or borderline between the new bone from the graft and the old bone is a cause for concern. My answer first is that the demarcation line does not a cause for concern in dental implant. Rather, the bone qualities comes from hydroxyapatite might be the major concern in advance. Let's go for an answer with upcoming clinical cases. The keyword for this question and answer is demarcation line and new bone from hydroxyapatite materials. Please remember. Here we have a first case which will be focusing on demarcation or borderlines. Left is the extraction of lower right first molar due to root fracture. In the middle, place the implant and put prosthetic abutment for temporization simultaneously and suture the socket with grafting patient own blood. It's so unusual to say graft patient own blood, isn't it? Right is 5 years after with final processes. In the left CBCT, there was no significant demarcation line around the root before extraction. That means there was no inflammation. The border between the graft, patient own blood, and the old bone was shown as radio-opaque line, also known as parental ligament or alveolar bone proper. 4 months later, the white radio-opaque border was almost disappeared. Subsequently, the line was eroded and mixed with newly formed bone, and 5 years later we can distinguish the demarcation line, and there is no difference between the old bone and newly formed or healed bone. As a conclusion of this case, the disappearance of borderline, demarcation line, parental ligament is significant in extraction socket healing. Okay, this is the second case to answer, focusing on radiolucent lesions around the root on lower right second molar. That means inflammation in and around the remained alveolar bone. Keeping in mind of the question cases in the left where there is a periapical lesions, the lower right second molar, this case has broad radiolucent periapical lesion, which look like more advanced lesions than the question case in the left. Left is the post-extraction CBCT on number 47. The border is irregular and the parental ligament line destroyed. That indicated remained inflammation in the old bone. Middle is the socket preservation with moldable auto-BT dentin powder without membrane. 4 weeks after extraction. Again, 4 weeks after extraction. During this 4-week period, we generally expected the coming out of the inflammation from old bone. We can see the dentin powder packed in the socket and the demarcation line, which represent the loose packing of the dentin powder. In right CBCT, 3 months after socket preservation with moldable orthopedic dentin powder, we could focus on 2 major points. One is the disappearance of demarcation line in between the old bone and dentin powders, where new bone was formed and fused each other, old bone and graft materials. Second point is the changes of each dentin particle loosely packed. Distinguished each particle in middle CBCT has been conglomerated and showed increased radiopacity. That explains the resorption of each particle and enrollment into bone formation. As a summary of this case 2, first, waiting at least 2 to 4 weeks to get rid of the remaining inflammation in the socket is highly recommended. Second, loose packing of osteoinductive and osteoconductive dentin powder or hydroxyapatite materials for securing interparticular space is desirable in order to get enough blood supply from old bone. Third, disappearance of demarcation line is a strong evidence of union between graft material and alveolar bone. That is the beginning of the remodeling. This is the case to answer that is very similar to my friend. Extract the root rest with the broad periapical lesions, socket preservation with moldable orthopedic dentin powder immediately. The only difference was to place the implant simultaneously. Keeping in mind of my friend's case, let's see the video. After extraction of the root rest of the lower right second premolar, place an implant. You can see the secured space between the implant and the buccal wall to be repaired. A soft tissue release by using incision on sound bone, and do subperiosteal tunneling the mucosa up to the free gingiva. Confirm the release. Prepare moldable orthopedic for socket preservation, make it into a spherical shape, transfer it to implant site, put it into socket with light pressure. Do not apply too much pressure for tight packing, and you will find the dentin powder soaked with the blood. Like this. See, it's not moving due to collagenous nature of the dentin, even with the cause biting or cause pressure. And then suture without membrane. Even if there is no primary closure, approximation is satisfactory in case of sufficient blood coagulation. Incision will be left open. Let's take a look at the soft tissue healing of this case 3. Approximation suture is enough, provided a sufficient blood fills the open area. In other words, the collagenous nature of dentin particles hold the blood sufficiently, so they will go through the same natural healing pathways as extraction sockets. The incision left open on the sound bone, you can see an eventful healing with the pseudomembranes on the first day. This is on the 12th day of before stitch out. The wound contraction has already been completed. Even though the cover screw is slightly open on 25th day, there was no inflammatory responses due to excellent biocompatibility of dentin particle. In particular, the UM's incision line is almost healed and formed scar tissue at 25th day as well. Just to see the result at 2 months. Type 1 collagen of dentin powder soaked with blood in the left open wound went through the same healing pathway as socket healing. The resulting incomplete close of the soft tissues of cover screw after 2 months on the right picture. Therefore, there is no need to worry about food infection or loss of bone graft material when using these dentin powders. UM's incision on the sound bone, which was left open, has formed a scar and elongated the attached gingiva at 2 months later. In addition, this UM's incision can reduce swelling and pain by avoiding vertical releasing incision and flap reflection in the early postoperative stages as well. Excuse me. With regard to bone healing with dentin particles of this case 3, in the left CBCT, see the root rest with broad radiolucent lesion before extraction. After implant placement, dentin powder was packed loosely into 2/3 of socket. And to induce natural healing, just like the first case I mentioned before, apical 1/3 is left empty, where actually patient own blood was filled with. 2 months later, you can find newly formed bone in apical 1/3 area even with patient own blood. On 2/3 of sockets, the dentin particles were conglomerated and showed increased radiopacity. That is evidence of particle resorption and new bone formation. I would say the advantages of loose packing of moldable authority dentin powder are not only plugging the whole socket with patient own blood, but also provide the space for turning the inflammatory bones into regenerative bone. As a summary of this case 3 is when using dentin powders with sufficient blood soaking, healing pathways are in line with natural extraction socket healing, even without membrane, because after 2 months of loose dentin graft, first, there was nature of type 1 collagen in dentin powder formed bone of a cover screw without any resorption or exfoliation. Second, apical 1/3 of inflamed area where only blood filled has been changed to newly formed bone at 2 months. Third, the volume and shape of dentin particles we put are maintained with new bone formation without membrane. If you have any questions or comments, please leave a message and we'll prepare an answer and we'll upload it. Thank you for your kind attention. This has been Dr. Um.